Welcome to the Hurley Healthy Living Joint Replacement Virtual Event. Tonight, Orthopedic Surgeon Dr. Telehowski is going to explain the latest technology being used in knee and hip replacements and shoulder, elbow, and hand surgeries. You might not be aware of this, but Hurley is one of the leading joint replacement programs in the country. We're one of only 2 Project Joints exemplar hospitals in the state. Now, before we bring on Dr. Telehowski, we do want to make sure you know that Hurley is safe when it comes to COVID-19. Not only are we screening patients and staff, staggering appointments, and wearing masks, our team is going beyond, way beyond the 7-step cleaning process in patient rooms. We have taken the germ-zapping robots used to sterilize surgical rooms, and we're using them as another line of defense in patient rooms to make sure you are safe in the hospital. What's great about an event like this is that it gives you a chance to talk to the surgeon, ask him questions before you've even scheduled an appointment. If you post on YouTube or Facebook, we'll get your questions answered here live. Dr. Telehowski, MD, is a board-certified orthopedic surgeon with over 20 years experience. His area of expertise is joint replacement, trauma, and sports medicine. Born and raised in Michigan, Dr. Telehowski completed his undergraduate degree in science and chemistry from the University of Michigan, Ann Arbor. He earned his medical degree from Wayne State University School of Medicine. Dr. Telehowski joined Ortho Michigan's team in 2004 and his offices in Lapeer and Flint. When he's not in the operating room, Dr. Telehowski enjoys spending his time with his family and rooting for the Tigers, Red Wings, and Lions. Well, let's get to it. Welcome, Dr. Telehowski.
All right. Well, thank you, Peggy, for the nice introduction. My name is Paul Telehowski. As Peggy said, I'm one of the orthopedic surgeons here at Hurley. And tonight I've been asked to give this presentation. I couldn't be more excited about it. I wanted to reiterate what Peggy said earlier about Hurley being a safe place to have your medical care done. I think it's important. Myself as an orthopedic surgeon working there, I've been so impressed with the amount of attention they have placed on this, and with the current situation we've been going through. I just find this to be extremely important. And the level of detail that Hurley has provided, I think, is wonderful, and I wanted to make mention of that again. And I think that's important to all the folks out there listening this evening. I appreciate everyone joining me tonight. I've got some interesting topics to talk about. Hurley has recently offered me the opportunity to obtain a new instrument that we're using in the operating room, our Rosa Robot. We're going to be getting into a little bit more of that later. But that is part of the reason why this presentation is happening tonight. To start out, this presentation is going to cover some topics about the topic of arthritis in and of itself. We're going to talk about some of the conservative treatment options related to such, in addition to some of the surgical options that can be offered when treating knee and hip arthritis. In addition then to some of the pre and post-operative care that patients can expect to receive when considering these as options. And at the end, we're going to open this up for questions and answers. I usually find that to be the most interesting part of the presentation, and typically when most of the information regarding these topics is really given. So what is arthritis? Certainly it's a very common condition. It is one of the most common medical conditions that affects the population. It is a degenerative joint disease. In the United States, affects over 30 million U.S. adults. It occurs when cartilage, or what we call the cushion between the joints, breaks down and often then leads to pain, swelling, and stiffness. Some of the risk factors, some of the patients that perhaps we will see that are prone to this are patients that have potentially had a previous injury, potentially overuse. Sometimes as people age, their joints start to break down and become degenerative. Gender can play a role in that. Weight obviously can play a role in that. And sometimes simply genetics. In other words, patients may be predisposed to it because of a family history. We can look at arthritis as either inflammatory or non-inflammatory. the more classic variety of osteoarthritis being the non-inflammatory, sort of the wear and tear form of arthritis. And then some patients may present with rheumatoid arthritis, meaning more of the inflammatory component that can affect multiple joints throughout the body. When we see patients related to arthritis, certainly they present with pain. That tends to be the most common symptom. Beyond that, patients will complain of either a stiff or swollen joint. Many times their symptoms worsen with activity, such as walking, bending, stooping, or stair climbing. Many patients may report weakness or buckling, especially within the knee. And many patients then will, as a result of all this, report problems with their gait or ambulation, either with pain or limitations and such. In the office, when we see these patients, we will certainly see the involved joint, especially the knee, to have a limited range of motion. Sometimes we'll notice grinding or what we call crepitation within the joint, feeling almost like sandpaper within the joint. In the office setting, we typically will order x-rays to evaluate. This is the most common test involved to look for arthritis of the joints. We'll usually obtain x-rays with the patient standing on their knees. And in many instances, this is where we sometimes will see the very common finding of bone-on-bone arthritis with complete loss of the cartilage. Some patients may require an MRI, although in most instances, this is not necessarily needed to diagnose the more advanced cases of degenerative arthritis. And in some cases, if suspicion is given for the more inflammatory types, such as rheumatoid arthritis, there may also be blood tests that can be ordered. On this slide here, we have a couple examples, both artistic representations and also radiographic representations of both hip and knee arthritis. On the left side of the screen is the classic findings of the hip. On the bottom left, there's a x-ray of what is a relatively normal hip with good joint space between the head of the femur and the socket side. And then right next to that is a classic example of a hip that has pretty severe arthritis with complete loss of the joint space. Again, the classic bone-on-bone finding. And then on the right side is an example of the knee with, again, an x-ray of a very normal-looking knee with good space between the bones. And then on the far right, a very classic example of a very degenerative knee where the cartilage has completely been lost and the bones are making contact on each other. Initial treatment for knee arthritis or hip arthritis typically involves some form of increasing physical activity. Many patients might say that their knee or hip may hurt more with increased activity, but it is actually very important to try to keep the joint moving, to keep the muscle strength up. And so in many instances, attempting to increase some physical activity in the face of some arthritis can actually be beneficial. This is sometimes where medications can play a role in helping to reduce the symptoms. Medications such as non-steroidal pain relievers, sometimes steroidal medications. In some of the inflammatory diseases, there may be disease-modifying agents that can be prescribed for the rheumatoid arthritis type patient. Physical therapy and weight loss play a big role in the initial management of knee arthritis. Unfortunately, with heavier patients, knee pain can be accentuated because of the increased weight patients are carrying around. And weight loss in and of itself is actually a very good form of treatment for the especially painful arthritic knee. Many patients with appropriate weight loss report marked decrease in their symptoms when having an arthritic knee. And so it is a big goal early on in the treatment of arthritis is to promote weight loss and increasing range of motion and physical therapy. Occasionally in the office, we'll provide steroid injections to help relieve symptoms. We do also have another product, viscosupplementation injections. These are more of what patients describe as the classic chicken shot injections. These can also be helpful in providing some pain relief within a knee. When none of these options are working well and patients are good candidates, surgery can be considered. And in this instance, when knees completely wear out, total knee replacement can be the option for patients. Patients may ask many times when it's the right time to get a knee replacement. It can be a little bit of a challenging question to answer accurately, but certainly we do know that when knee pain limits everyday activities, when pain is consistent, when patients are having pain both with activity and at rest. Classic example I will hear is that patients even find it hard to sleep through the night because of their knee pain. These at times I think are indications that perhaps knee replacement may be the right option at that point. Certainly after a knee replacement, I'll get many questions what patients are able to do after a knee replacement. And I'm happy to tell them that they really can do everything they probably were doing before a knee replacement, but with much less pain. And so unlimited walking, golfing, swimming, driving, hiking, low impact sports such as tennis certainly are allowable. We do understand that after a knee replacement, more high impact activities such as running or jumping, these can be challenging or difficult, and we don't necessarily encourage patients to perhaps take up these activities as they can cause a large amount of stress across the replaced knee. But certainly patients are able to find getting back to their normal routine daily activities, walking through the grocery store, playing around a golf with their friends. Those are certainly accomplishable goals after a successful knee replacement. So this is the Rosa knee system that I think was shown on one of the first slides. Rosa is a computerized knee system used in the operating room. It was developed by Zimmer Biomet. They're a large company that makes knee implants. I am a surgeon that uses their implants, and Hurley has now obtained one of these robots for my use and a couple of my colleagues' use. We've had some experience with it already. It is a wonderful piece of technology we're now using in the operating room. I'm super excited about it. I look forward to using it now when I am at Hurley doing my knee replacements. This is a computerized system that allows us to see in real time in the operating room structures of the knee. It allows us to better visualize the alignment of the knee. It allows us to get real-time feedback to be able to measure detail in more accuracy than we were able to do before. And as a result of being able to do this, I think overall we anticipate to see hopefully better results with our knee replacements. I think what this robot is doing now is taking what was already a very successful procedure and adding more science to it. I think by adding that increased science, I think we can be more precise and more accurate in how we're doing these surgeries. And we think in the end, and what we're hoping in the end, is that by using this technology, we can even make increased improvements on what, like I said, was already a very successful procedure for patients. So it's exciting technology to be able to use. I'm very honest with my patients. This isn't necessarily something that when patients go to the operating room, they appreciate, because patients are asleep in the operating room. It's a tool I'm getting to use when I'm doing my knee replacements. But I'm super excited about it, and I think overall it's going to be a marked benefit to the patients that I'm going to be able to use this on. So I congratulate Hurley on obtaining it, and I've been super excited again to be able to use it. So it's something that I hopefully translates well into our patients. A little bit on hip replacement, because I also do hip replacements too. Hip replacements are very similar to knee replacements in what they accomplish. The hip replacement certainly in a patient who has hip pain that limits their activities, they have pain at rest. Hip replacements are procedures that do well in patients who have not done well with more conservative measures such as anti-inflammatory medications or injections. They allow, again, patients to perform unlimited walking, playing low-impact sports, hiking activities, driving. And so hip replacements, much like knee replacements, incredibly successful procedures, and patients do very well with these. When patients do decide on having a joint replacement, there's a very few small things that are done ahead of time out of the office. Some patients need a medical evaluation if perhaps they have a few underlying medical issues. Usually we'll ask them to see their primary care physician. If maybe there's a history of some cardiac issues, we may require cardiac clearance from their cardiologist. This usually isn't a big issue. It just needs to be done so that we have that information available to us before surgery. We do ask that patients have their dental procedures performed before surgery. We don't want them to be getting any type of dental work done in the immediate period right after knee replacement, as this can be an increased risk for infection. And similarly with urinary procedures, we ask patients to have those issues evaluated and taken care of before joint replacement would be considered. And then as far as home planning, we do ask patients to attend our joint replacement class. It's a small little class we do before the procedure where we run over some of the some of the more everyday issues that may come on after a joint replacement, such things as simple things such as maybe safety bars in a bathroom, a shower chair, a toilet seat riser, potentially considering maybe just readjusting some living space in the house for a very short period of time, especially if maybe a bedroom is upstairs. Although patients are quick to get back to doing stairs, there may be a few days to a week where it might be a little easier to have a little bit of a temporary living space in the house on the downstairs floor to avoid the stairs. But honestly, most patients within a week of having a joint replacement, whether that be a hip or a knee, are typically able to accomplish stair climbing. So the need for rearranging living space within the house is usually a very temporary issue. On the day of the procedure, patients will arrive to the hospital. The surgery itself, these procedures are performed under spinal or general anesthesia. We do ask our anesthesiologists their input in performing, obviously, those procedures for patients. Our knee replacements now are getting what we call adductor canal blocks. This is a nerve block that is done in the preoperative area. It has been a wonderful procedure performed. It allows patients when they wake up, get moving, get walking. Their knee is overall relatively numb. We have now seen with these type of nerve blocks, patients are up moving and walking 2 to 3 hours after their surgery, walking down the hallway, perhaps only leaning a little bit on a walker. And really wonderful in their pain relief. The procedure itself is about a 1-hour surgery. It's about 2 hours for patients because it takes a little time to get you in the operating room, go to sleep, wake up afterwards. But the actual procedure itself is about 1 hour. Patients spend about 2 hours in the recovery room after the surgery. And from there, at Hurley, our patients are taken up to what we call our joint replacement floor. This is a private floor in the hospital, really nice, quiet setting. The rooms are very nice, kind of private rooms. The therapy is right there on the same floor. Our nurses on the floor are specialty trained in joint replacement cases. But the big goal there is to get patients up and get them moving. The afternoon after the surgery, they are up down the hallway working with therapy. Most patients will stay overnight, one night. I always tell my patients nothing real special overnight happens. It's kind of a nice hospital, hotel room for you to stay in. But then the next morning, patients are up with therapy again, usually working on some stairs. Patients typically will pass therapy on that day, be cleared by the therapist to go home, and we then can allow them a discharge on day one. And so in our program, the average length of stay typically is a one-night stay. Once patients get home, we usually will have them on some medications, a good non-steroidal anti-inflammatory pain reliever. We will also put them on a little bit of Neurontin for pain relief, a little bit of a nerve medication. We do use a little bit of narcotic medication, usually about 2 weeks worth. We try to keep the dose low. We like patients to be awake, moving, responding well to therapy. Patients will typically need some form of blood clot prophylaxis. There is a small risk of getting blood clot when your knee or hip is operated on. Currently, we tend to use aspirin if patients can take it. There are other options. But aspirin has been a very easy medication for people to take, and so it works well for this. Once patients get home from the hospital, usually within 2 to 3 days, physical therapy is started. This is most typically an outpatient program where patients are going to therapy. Probably the biggest issue there is that when patients have their right side knee or hip replacement, many patients do need help with driving, of course. With a knee replacement, hip replacement, it's about a month, especially when it's done on the right side. It's a little quicker on the left side for a lot of patients. And then in my office, patients come in at the 2-week visit, the 6-week visit, and the 3-month visit. Usually those are the 3 standard visits back in the office. We kind of monitor the progress in therapy during that time. But what I tend to find in my practice is usually by about 3 months, whether it be a hip or a knee replacement, most patients are overall doing well at that point. And although they may not be at 100% recovered, by 3 months, most patients I feel very comfortable allowing them to be discharged. I know over a few more months they'll get a little bit stronger. Their activity will increase over that time. And so usually it's those 3 visits after the surgery. So we look forward to having questions. I think we've already had some brought up, and I'm going to ask if we could have those questions read now.
So a patient from Midland actually called us and saying that their surgeon told them that they were too overweight for knee surgery. Are there weight restrictions for these surgeries to have them?
Certainly, we look at weight as one of the medical issues amongst others when patients are considering hip or knee replacement. Um, we look at weight much similar to the way we look at some other common medical issues, because all of these things can create increased risk related to surgery. And so weight in and of itself can be an issue at times. There are some studies out there now that do indicate that patients who are heavier may present with an increased risk of complications related to surgery. Most orthopedic surgeons around the country, we look at a number called the BMI, or body mass index. That is a ratio of both weight and height. I always tell my patients, if you have a smartphone, it's very easy. You can type in BMI on your smartphone and a chart will come up and you can look at your height, your weight, and see where you fall in that. But we typically will want a BMI of under 40. There are some studies that have come out over the past few years that indicate if your BMI is increased over that, it does present an increased risk of complications related to surgery. And so when we look at that as surgeons, I always like to make sure my patients are going to do well with surgery. And if I have a factor that we can potentially change before the surgery happens, I think that's always a good discussion to have with a patient to help modify those things so that we can be sure that we're eliminating the risk of surgery. It's not much different than, honestly, if a patient comes in and claims to be a 1-pack-a-day smoker, because that in and of itself is a risk for surgery also. We see, unfortunately, higher rates of infections, blood clots in patients that have these type of medical issues. And we do consider these to be adjustable. I think if patients get into the right programs, these factors can be altered over time. And with that, then, we can then do good quality surgery. And so we do really push for that when it comes to some of these issues, weight being one of them. That's an excellent question.
You talked a little bit about the Rosa Robot and how that's making surgery so much better now. But there's a question about who's doing the surgery. Is it the robot? Is it the surgeon? Does the robot help you?
I think that's an excellent question, and that's what I'm excited about with the Rosa Robot now. It is me doing the surgery. I tell people it's sort of like the airline pilot. The pilot's still flying the plane. He's just got a lot of complex equipment that's helping him fly the plane. And I think that's important. There are a few robot systems out there that are a little bit different from this. These robots are taking the equipment out of the surgeon's hands, and I never liked that idea. I looked at those as options, but I never truly felt comfortable with it. I always tell my patients, I went to school, and for 20 years I've learned how to be a surgeon. Why am I going to let a robot now take over what I'm doing? The Rosa Robot, I like to call it more of like a high caliber measuring tool. It's giving me feedback in the operating room to make adjustments. In reality, the equipment, the surgical tools are still in my hands. And I think that's important. When I first saw this technology, I have watched some other surgeons who utilize it. That's how I learned to use it. And that's what I really liked about it, is that I was still the surgeon in charge. I still feel like the airline pilot who's flying the plane. And to me, I think that's important when it comes to doing these type of procedures.
Well, in addition to just the pain dictating when somebody wants surgery, I know a lot of people kind of schedule it based on what's going on in their life. They don't want to be laid up. They don't, they want to make sure it's at a good time. And we did get a private Facebook message asking how long before I'm able to get back golfing after knee replacement.
Yeah, so again, a little bit varies patient to patient. There's no doubt about that. Not every patient is the same as the next person. But what I tend to find is a patient who maybe is an avid golfer, likes to play maybe a few times a week, is in his overall good shape. I think most people, if they're going to play golf a few times a week, tend to be patients that are in pretty good shape to begin with. I think those patients within 2 to 3 months are able to get back on the course and start playing. I kind of jokingly tell my patients, I say, right after a knee replacement, you're going to be able to putt and chip all you want. But it might take you a little while to pull your driver out of the bag and hit the ball 250 yards down the fairway. That still takes a little bit of practice. But I think overall, patients who enjoy those type of activities, knee replacement can get them back to that kind of stuff within a couple months to 3 months. I think that's very reasonable. So I think it's a great question.
Do you have to wait until you're older does the surgery only last so long? I think somebody doesn't want to have to get it and then 10 years get it again, 10 years get it again.
Yeah, and that's again another excellent question, and that was actually a big issue some 20 years ago when I first started training, because the technology regarding knee replacement I don't think was as good as it used to be, or good as it was back then. Age has become a little bit less of an issue when it comes to joint replacement. We're still not putting these in people who are in their 30s and 40s typically, but certainly patients who are in their mid 50s and up can absolutely be candidates for knee replacement. That is because I think the technology has gotten better, the materials they're made out of have become better. The issue 20 years ago was that what we saw is that over some years, especially knee replacements and some hip replacements, some of the components within the knee could wear on each other. Patients could get into a situation 10, 15, 20 years out where their knee replacement has worn itself out. I tell people, much like rubber on your car tires, if you put enough miles on them, they will wear. So I think more recently now, with better technology, a little bit younger age range patients are able to now undergo these procedures. Again, we still like to avoid the issue with maybe the patients in their 40s. I don't think we can expect a current knee replacement necessarily to last 40, 45 years in those type of patients. There could still be issues with them wearing out. But we are now doing knee replacements and hip replacements, certainly in patients who are in their mid-50s, with great results regarding that.
If someone calls today, how quick can they expect that they could actually have the surgery?
Yeah, so we at our office we absolutely have a commitment to getting patients in very quickly to be seen. That's right up front has been a big goal with our group at Ortho Michigan, to get patients in and have them seen quickly. When patients now call to make an appointment in our office, we will absolutely try to get them in, usually within 48 hours into the office to be seen by one of the either physicians or one of our our physician's assistants in the office. If patients come in, are evaluated, and let's say they are a good candidate and are interested in knee replacement, usually at that point between scheduling some of the preoperative classes that we would ask them to, or I should say the one preoperative class we ask them to go to, usually it's a 3 to 4 week period of getting them scheduled, getting them on the schedule, and then getting the surgery done. So usually the answer to patients is usually within about 3 to 4 weeks.
This question is pretty specific. I'm 48 years old. I've had 2 hip replacements last year due to osteoarthritis. And what are the chances of me now needing a knee replacement? And what can I do to slow the arthritis?
A little hard to know until we actually would evaluate your knees. Given the fact that you've had some hip replacements, there could be some pre-existing knee arthritis. It's a little hard to say without looking at the x-rays and evaluating. But certainly at that age, it's obviously a little bit younger on that side to have hip replacement, but hip replacement, again, it can be a very good procedure in a patient who is of that age. We seem to find that hip replacements perhaps maybe have a little bit longer longevity, and so age in and of itself with hip replacement doesn't tend to be quite as big of an issue compared to knee replacement. But again, I think in this example, this may be something that would have to be individually evaluated in the office, I think, before an absolute specific answer could be given.
But there can be connections or not connections as far as arthritis and all these different joints.
Well, sure. I certainly have patients who, unfortunately, especially if they have a strong family history, can have multiple joints that over their lifetime start to degenerate. With that being said, though, I've seen patients who have, for example, terrible arthritis of both hips, yet you look at their knees and they don't seem to show evidence of any arthritis with either knee. So again, on an individual basis, a little bit hard question to answer, but certainly with a history of having 2 hip replacements, there may indeed be some need to have the knees looked at.
Someone's asking, if you have a knee replaced and then it wears out, is it more difficult to replace it a second time?
Not always. Certainly revision surgeries are a little more concerning because they can at times be bigger surgeries. Sometimes if caught earlier, the revision surgery may not be as big as the first surgery. Again, there's variability amongst those in that answer. So it's a little bit hard to answer concretely on that. Again, this is why we look at certain factors such as age and weight, things that may play into a role of the knee wearing out over time. And so that's why, as we talked about earlier regarding that, those are important things to be evaluated individually amongst patients.
How long before you can go back to work, someone's asking, like if they have a desk job?
Yeah, well, certainly there's different types of work. There's folks that sit at a desk and then there's guys out there that are digging ditches for a living. So there's marked difference depending really on the level of work. I have had patients who they may be working at a desk. They may own their own company. They're not really doing heavy manual labor. I tell those patients they are able to go back as soon as they feel comfortable. I've had patients back to work at 2 weeks sitting at a desk. I tell those folks that sitting at home, your knee doesn't know the difference whether it's sitting at home or sitting at work. Now, certainly patients who maybe do more standing work, let's say a cashier, I give patients the classic example. If you are a cashier at Walmart, you're standing for an 8-hour shift, you're not necessarily doing repetitive heavy lifting, but the job requires you to stand and move around. Those patients may need anywhere from between 2 months to 3 months before getting back to work. Certainly if there's more heavy activity involved, lifting, squatting, a lot of stair climbing, this could be a little bit longer, sometimes between 3 to 4 months before patients may actually be able to get back to that type of job. I always give patients the extreme example. For example, if you played in the NFL playing football and you hurt your knee and had a knee replacement, I hate to say it, but your career is probably going to be over. Because at that level of physical activity, I don't think there would be anyone that's unfortunately going to hire you to do that type of job. So there's certainly a lot of variability in what people do for work. So there's a lot of variability in when they can actually get back to work. But certainly the lower demand work, patients get back much quicker than if patients are required to stand and carry and climb on their job.
Do you ever do both knees at one time?
Not advisable. I think in my hands, I would not recommend that to my patients. I can say in the past that was done, but I think as more science and studies have come out, what we probably have found is that it tends to create more risk for the patient. And although patients may hesitate to not want to have one done, wait, and then have the other one done, in reality, if we're doing it more safe that way and patients, then we know patients can do well related to that, I think that is overall the better option for patients. Doing them both at the same time creates a lot more risk to the patient. We certainly, in the past when that was done, saw patients spend much longer times in the hospital. Many times they were needed ICU stays. And so we tended to get away from that because, like I said, what we're seeing now is by having a single knee done, patients are able to get up, move around 2 hours after the surgery. We're able to get them out of the hospital the day after the surgery and get them into a therapy program. I will typically tell my patients I will fix their second knee usually at about the 3-month mark. I want to see them recovered well from their first knee and making sure they're doing well. And then patients will come back and we'll do their second knee. You have another question?
I do. I'm trying to read it here. So someone says, I have hypermobility Ehlers-Danlos syndrome. Sorry if I butchered that.
That's okay.
And my hip has been dislocating for most of my life. Now the femur is out of place at the hip, rotating and causing discoloration of the knee. What would you do with someone like me?
Yeah, so again, it's a little bit of an individualized question, a very unique problem, and these type of questions. I think the best answer initially is come to the office. Let us take a look at what the specific problem is. It's certainly something that potentially could have a solution, whether it's a hip replacement or not. A little hard to know based on the information in the question. But anytime I get questions like that, I always encourage those folks. Make an appointment with me. You see the number on the screen there. Give it a call. We're happy to take a look at it because doing this over the web like this, a little hard to give people absolute concrete answers because it's a little hard without an X-ray in front of me and an evaluation to give absolute concrete information on that. But certainly we'd be happy to take a look at it and see what we can provide.
I know you did address this in your presentation, but we did get another question about weight and how does weight factor in regarding knee replacement?
Yeah, so again, weight plays a role because what we know is that the increase the weight is, the increase the risk goes up with surgery. And that actually is not unique to knee replacement. And surgeons that do other types of surgeries will say the exact same thing. And this is why, because when we take our patients to the operating room, we want them to do well. And by getting their weight down preoperatively and getting it into a safer range means we know that patient has way less risk for complications after surgery. The studies now have shown, unfortunately, that elevated weight relates to increased risk of infections after joint replacement, increased risk for blood clots after joint replacement, and potentially even increased risk for other problems such as heart attack, stroke, and anesthetic risks. I kind of tell my patients when it comes to that issue, I use the analogy that having your knee replacement is much like when NASA launches a rocket. You don't push the start button if someone's telling you something's wrong with the rocket, because something bad could happen if you push that button. And so we really try to maximize or minimize the risk before patients actually get to the operating room. So things like smoking cessation, weight loss, getting the diabetes under control so that we don't see these problems afterwards. We really don't want people to go through these surgeries and have poor outcomes. They're not happy because of it. And these things directly relate to that. So again, I'm glad almost it's asked twice, because believe it or not, it is one of the more common questions I get asked in the office about it too. And we're consistently having these discussions with patients about these issues.
Someone is asking about range of motion. Will they have the same range of motion after surgery that they have now?
A big predictor of range of motion after knee replacement is what patients have preoperatively. We do expect range of motion overall typically to increase for many patients. We do know that if patients, however, do start out with a very, very stiff knee, there can be some issues in overcoming that postoperatively. Many patients might say that stiff, painful knee, it definitely feels better, but sometimes when you look at them, they may still have somewhat of a stiff knee after the knee replacement.
I think this is the final question.
Excuse me.
And maybe came through because so many people are trying to juggle so much right now. They're teaching their kids, they're doing all that stuff. Once you get home, is someone going to have to help you with things and care for you for a while?
Great question. Great question. What believe it or not, what I tend to see is people over plan for these surgeries, and that's not necessarily a bad thing. But I think patients really think they need to upend their life sometimes when they have these surgeries. But in reality, I kind of tell them, you're already doing all of your activities with a bad knee or a bad hip. And so we're not really making you worse here. We're fixing the problem. We're making you better. And so I think early on, what I tell my patients is, you won't need nursing help. You'll be able to get up, walk around your house. You can go to your kitchen. You can make your lunch. You'll be able to do that. What patients need maybe help with for the first 1 or 2 weeks are maybe some of the chores around the house, because most patients will typically have a walker in front of them or a cane. And so what they find is difficulty perhaps carrying things. So getting groceries, maybe doing the laundry. I don't think people need 24/7 care after these surgeries, but certainly it's nice to have someone in their back pocket that they can rely on for some of these other activities, such as getting the groceries, going out to get the mail, maybe if they need the lawn done. Those are activities sometimes that people will need help. Probably the biggest one I see is the fact that when patients have these surgeries, they definitely need someone for transportation, because we do require patients to attend therapy afterwards. They're going to be expected to go, and for the first couple of weeks, they're not going to be able to drive. Combination of both having had leg surgery and also being on a little bit of pain medication. So we absolutely need a little bit of help on that end. But certainly patients are mobile. They're up moving around. Like I had said earlier in the talk, 2 to 3 hours after these surgeries, patients are up moving.
Someone says they can't wear heels now, but can they after surgery?
Uh-oh. I do have a lot of women. I don't want to make it one-sided there, but I do have a lot of women who say because of their bad knee or bad hip, they have a whole closet full of high heels, and now they find they can't wear them. I think over time, after people recover and they get more confident and more comfortable with it, I do think a lot of people can get back at it. I don't necessarily know about the 4-inch stiletto heels. I'm not sure about that one, but I certainly do hear patients tell me that for a long time, because of their bad knee or bad hip, they have a closet full of these fancy shoes they can't unfortunately wear. But it's kind of nice to see. I think patients get a little further down the road and you start to see that come back. So sometimes the small things in life like that make a big difference.
Someone says they have arthritis in their right knee. They've tried shot therapy and medicine, still have pain. Can knee replacement help?
I think that's the classic example of a patient who we can help. I think that is, in reality, a very common situation. Patients will go through what we call more conservative treatments. We try to get them better, avoiding surgery. And that is a patient who I think has gotten to the point where these conservative treatments have, unfortunately, they're not working. And this typically is when surgery starts to play a role in getting these patients better. I kind of tell patients, I typically, in my practice, do everything in my power to try to help people out avoiding the operating room. That's a big part of being a surgeon. But the nice thing is then if patients get to a point where those things aren't helping, we have the ability with the surgery to make them better. I appreciate everyone joining us tonight. Hopefully this has been informative. Again, I want to thank Hurley for putting this all together. And I appreciate the great questions that everyone chimed in with. Thank you very much.
What great information. We can see you golfing or kneeling down, planting in your garden already. If you want to make an appointment, the information is right there on your screen. We also have the information in the descriptions on YouTube, Facebook, and at hurleymc.com/live. We hope this has been helpful and you continue to live out the year as healthy as possible. Good night, everyone.